Hello, everybody. My name is Max Knight. I am a athletic trainer here in Indiana. I currently work in a high school setting, and I am also a first-year student in the Indiana State University Doctorate of Athletic Training program. And this presentation is just my reflection of an ankle evaluation for an ankle sprain. We'll go step by step through that chronologically. We'll go a little bit in depth as far or regarding a SOAP note format. And then after that, we will talk about weaknesses in this type of evaluation I usually do, identify the gaps, and then kind of talk about briefly how I can fill in these gaps and become a better clinician. So let's get right into it here. So in my current evaluation for an ankle sprain, the first thing is when the patient steps through the door frame in my facility, and I see that they may be hobbling in, they may be like compensating because of pain. They may have some odd orthopedic devices or like an ACE wrap from home. It's just really important to kind of, quick observe how they're walking, how they're carrying themselves, just because that could help you or myself figure out or get an idea of what they may be coming to me for. And then next thing, got to be friendly, got to get to know your patient. So quick, ask them their name, what grade they're in, what sport they're in. Ask what they're in for, get a quick synopsis of the mechanism of injury, and then kind of when they're talking, I like to sit there while they're sitting on the examination table and just get a quick brief look, see if there's any like swelling, bruising, anything like that, and then just quick grab a SOAP form, and I begin my documentation by getting their birthday, their grade, their sport, quick mechanism, and then the date of injury, because most cases, some patients, they may sprain their ankle or roll their ankle over the weekend and don't think about coming until like a Tuesday or Wednesday. So it's important to get that quick date of injury. And then also this information can be used to, maybe help them get an appointment with a physician and kind of have that information ready for that. Moving on, jumping into the subjective portion of the examination, I get a full mechanism of injury. I ask if they have had any previous injuries to that area, kind of open-end questions like that, just to kind of let them talk about anything that may have happened to them, if they had any surgeries, or if they had taken any sort of medications or any odd symptoms. Then I ask about any numbness, tingling into their extremities. I ask them if they've been doing any at-home treatments. Again, if they've been taking any medication, because that could kind of alter the treatment path. Next thing, I ask them what their current pain is. I usually use a visual analog scale with the faces on it, just because I think high school student athletes can better conceptualize where their pain is at through kind of a visual mapping of their pain. And then I like to ask them if their current pain now, if the injury happened a day or two before, if it's the same, worse, better. That just gives me a quick synopsis of where the injury is going right now or how maybe severe it could potentially be. Moving on to the objective portion. Again, I start with I forgot to put this in here, but always ask for permission before you touch the patient. And then I start with a palpation of the bones within the ankle, and then kind of also do a more in-depth visual inspection of the area. With palpation, we're looking for pain, crepitus, edema, ecchymosis, heat, deformity. And then once I kind of get a general sense of the area and palpate the bones I need to palpate, we'll go into soft tissue palpation, kind of look for the same things. And then we follow up with the ipsilateral extremity. After that, we move into passive range of motion, looking for good endpoints and pain, if any. Then we have active range of motion testing. Again, look bilaterally and look for any decrements in range of motion, strength, muscle endurance, and if there's any pain with that movement. I don't really get into resistive range of motion unless, I have a couple extra minutes and there's not a line of 10 kids or other patients outside my door. I kind of just skip right ahead to the manual muscle test. I just get the muscle groups kind of around the ankle that help move it. And then I perform special tests or tissue stress tests. Usually, if I suspect there may be a fracture or some sort of neuropathy, I'll include those tests to kind of rule in and rule out that. But if I just suspect that it's just an ankle sprain, I'll stick to the anterior drawer, talar tilt with inversion and eversion, and a Kleiger's test. So after I get all my objective testing in, I make my assessment. It could be high ankle sprain, lateral ankle sprain, medial ankle sprain. So I usually tell them that. Then I educate them about the structures that were damaged or sprained. I kind of try and conceptualize for them why it happened, how it happened, and the test that I perform to rule it in and rule it out. Then after that, we make a plan for the next 48 hours. I usually ask at this point if they have any questions or concerns. My standard, if there's a lot of swelling or if it's a grade 2 or 3, I give them an ACE wrap and ice right away. I educate them about how to put on the ACE wrap and what the reasoning for it is. If they're able to ambulate without too much pain, I still offer them crutches. I did have a boot, but a patient hasn't returned it yet. So usually I'll offer crutches if they feel that would better benefit them, or I'll offer it if I don't want them to be weight bearing. Again, depending on the severity of the injury, I will ask to call mom, dad, grandparents, aunt, uncle, whoever their guardian is. I'll tell them who I am. I'll explain my findings, what they need to look out for, what they need to do with the patient when they get home, and maybe even inform them that they may need to come pick them up, or help them find a way to get their car off campus or something along that. Just kind of help them with that and educate whoever will be taking care of this patient at home. And so now we're getting into the 5 improvements to gaps in my ankle evaluation. So kind of some gaps I found and some things I can improve on were being more patient-centered. I don't really, as far as what I've written here, I don't really think outside of the patient's injury. It's usually just focused straight on that. So that'd be more of asking about certain hobbies they may be missing out on, if they're going to be able to move around the house okay, kind of things outside of that injury. The next thing, observing gait in the objective section. I think if I kind of start implementing that in my objective evaluation and giving a good gait analysis of how they ambulate if they can, and kind of observe any compensations they may developed, which maybe could have led to their injury. Next one is that lack of time should not degrade the quality of the evaluation. And with this, I should be better at triaging patients. So if certain people need to be taped, I'll tape them real quick. If some people need to know what exercise they're doing, I'll get them going. And I'll save kind of the longer things for last, so I can give them the time they need for a good evaluation. Next thing is including a goniometer with range of motion testing, just so I can have something to use as a baseline moving forward. If they're going to be coming in every other day, we can track progress better that way. And then next one, giving patients like a written treatment or rehab plan, just so they don't forget, and just so mom, dad, guardians at home can they don't have to rely on the patient's memory to do the things they need to do to get better quickly. So again, these are gaps that I feel like I have addressed through this presentation. Again, I want to thank you for listening and watching, and have a good day.